the recording. 5th District Georgia State Nurses Association regular meeting, July 11th, 1963, St. Joseph's Infirmary.
Our Heavenly Father, we thank Thee for the opportunity of coming together to discuss our profession and matters pertaining to it. We thank Thee for all those who are here, and all those who are giving so unselfishly of themselves and their time toward the furthering of their profession. We thank Thee again for all Thy blessings to us. We ask that Thou will guide and direct us throughout this meeting, that everything which is done here might be done to the honor and glory of Thy name. In Jesus' name.
Thank you, Ms. Hudson. We need approval at this time of the minutes that were circulated March 14th. As you will remember, we did not have a business session on May 16th at the Nightingale service for our Nurse of the Year. So we would like for you to approve the minutes that were circulated, I believe, in the meeting. Do I hear a motion? That these minutes be accepted as circulated.
I move that the minutes are circulated in the district meeting to be approved.
Thank you. Is there a second? Thank you, Ms. Pope. Is there any discussion? Has it been too far back to remember a lot about the minutes? When you all in favor, will you please say aye?
Aye.
Contrary, no. The motion is carried. Thank you. We do have one communication for you. I'll ask Mr. Atkins, who is acting for Ms. Dixon tonight, to read for you at this time.
This is from the American Cancer Society, Atlanta, Georgia. We gratefully acknowledge your memorial contribution in memory of Miss Selma Balt Jordan. Notification has been sent to the mother of Miss Jordan, 446 Candler Street, Northeast Atlanta, Georgia. This thoughtful memorial gift will further the emergency battle against cancer through the programs of research, public and professional education, and service to needy patients, signed by C.A. Clayton. And then we had a note from the family of Miss Jordan acknowledging the grateful appreciation, kind expressions of sympathy.
Thank you, Ms. Atkins. Would you like to give the report of the treasurer?
Yes, I will.
Ms. Atwater is here.
Then for the district, we brought forward from May $3,950.05. Receipts total $513.63, making a total of $4,463.68. Disbursements $1,330.97, which leaves us clear in the bank $3,132.71. Checks out $321.69, agreeing with the bank's statement of $3,454.40. Obligations to the government taxes total $259.20. In state of Georgia taxes $5.76. The checks totaling $321.69. I mentioned to you we are living within our budget. If I may make the comment, we need 114 more members, so by the end of the year, we're hoping that you will help us get those members. This is a report from the, do you want?
Yes. Can we have a motion?
Yes.
Can we have a motion that the treasurer's report be placed on file?
I move that the treasurer's report be placed on file.
Second. All in favor, please say aye. Contrary, no. Motion is carried. Thank you. Now we'll listen to the report of the registry.
Report for June. Their income totaled $262 for the month, dues and billheads, and disbursements total $2,212.15, leaving in the bank balance a total of $10,821.85. They had 5 RNs, 4 part-time RNs, and in June they had 2 part-time of the practical nurses with 1 part-time. Let's see, 2 full-time and 1 part-time, signed Martha Carlton, bookkeeper.
And we need a motion that this report be placed on file.
I move register report be placed on file. Second.
Those in favor, please say aye. Contrary, no. Thank you,
Second, ma'am.
Ms. Bryce.
Thank you. Couldn't see it.
Do you have your report? You listen to the fact and report of the executive secretary.
Make mine very brief and give you the total of members that we have. Last year we had 1,216, 1 man, 1,215 others, with 7 associates. At the present time, we have 1,073 with 7 associates and 1 renewal for today, 3 applications for approval. Giving you the CESR Section 8, EACT Section 100, Administrative 200 plus 1 associate, General Duty 137 with 1 associate, Public Health 101, 1 associate, and Occupational Health 45. Private duty nurses 479 with 4 associates, and the renewal today is private duty, which gives us, with the applicants, 1,073, 7. We sent out you 1,500 district meters, 1,245 directories have been mailed. The doctors will be addressed Monday. The secretary of the Fulton County Medical Association is back, and we'll see that they're ready for distribution. We're getting ready for the manual, and have been very fortunate in having all the motions since 1947 typed for us by Ms. Garland's secretary, who's done a wonderful job.
Thank you, Ms. Atkins. At this time, we would like to have a motion to reverse the business and have our program. Our speaker is a little bit anxious to get going, I understand. Could we have a motion that we reverse the order of business and have our program at this time? Thank you, Ms. Wells. The second. Ms. Mays, second. Any discussion? All in favor, please say aye. Thank you. The floor is yours, Ms. Bryce.
I won't keep it long. We're real pleased tonight to have Miss Connie Thomas with us. Miss Thomas, as many of you know, is an inhalation therapist with Stansel's Oxygen Service here in the city. She is in various hospital settings, and some of you will know her, and you already know what a good teacher she is. You'd like to know a little about her, I'm sure. Miss Thomas is a native of Florida. I should say, I believe that she was born in Florida. She's lived in Atlanta 4 years, so that makes her a native. I think we would all agree. 6 months is supposed to do it, I understand. She studied under Dr. Forrest Bird, who, of course, invented the Bird respirator. And she has studied with Dr. Lester Rumble here, who is head of the anesthesia department, chief anesthesiologist, I believe, here at St. Joseph's Infirmary. Her official title is that of inhalation therapist, which is new, isn't it? We don't know too much about these people and what they really have to give us. She's going to talk tonight on current inhalation therapy. And I think that this is a very timely thing, and your committee on program felt that it was timely that we bring this in view of the rising incidence of chronic lung disease And as urbanization is more upon us, I think that we're going to see more of this. I wish I didn't. But the trend is in this direction. I believe I can use the word trend advisedly here. These machines are frightening looking, and I'm going to be frightened tonight because I have never been tested with one of these, and I have offered, if she wants a guinea pig, to be that. So if you all will kind of look out for me, I'll appreciate it. I'm sure I may need it. And now it is with great pleasure that I present Miss Connie J. Thomas, who will talk with us on current inhalation therapy. Ms. Thomas.
Before we begin, I'd like to thank Ms. Bryce for that very nice introduction. I think she was just very nice. I'd also like to thank you for inviting me to be here tonight. It's a real pleasure, and I hope we'll be able to answer any questions that you might have concerning inhalation therapy, especially about the machines that we'll be demonstrating here tonight. As Ms. Bryce said, there seems to be a current trend all over the United States and all over the world of chronic obstructive lung disease. And I think, first of all, it might be a good idea to review the diseases that indicate the use of IPPB therapy or intermittent positive pressure breathing therapy with these devices and what we try to do with the therapy. As all of you know, chronic obstructive lung disease such as bronchitis and bronchiectasis, and especially pulmonary emphysema, have a tendency to destroy lung tissue. Now, the signs and the symptoms of all these diseases are the same. The patients have chronic shortness of breath. Actually, as the disease progresses, they have continual shortness of breath. They have a great deal of fatigue, a great deal of restlessness, and they have coughing almost constantly with or without sputum production. The patient's bronchial trees are invariably narrowed by edema and spasm and the retained secretions that they can't get up. So the result of all of this that's going on in their bronchial tree and in their pulmonary system is that they have very, very little alveolar ventilation. So what we attempt to do with the IPTB therapy is three things. First thing is to restore alveolar ventilation. The second thing is to rid the system of the retained secretions. The third thing is to make the patient more comfortable and try to restore a little bit of the elasticity that he loses through these diseases. There are various types of IPPB devices in the field today, and we have two of them here, the pulmonary ventilator, which I think most of the hospitals still use today. And it's been used for years and years and years, and is still used mainly because of its low cost and simplicity of operation. I think I've heard several people compare the differences between the respirators, not only the Bird, but the Bennett and the Emerson is the difference between a Model T and a 1963 Cadillac. The respirators make quite a bit of difference in the diseases, and the difference comes about because of the flow rate that you can achieve with a respirator, positive pressure respirator, that you can achieve with the pulmonary ventilator. And by a controllable flow rate, we mean the ability to set an initial inspiratory flow of air slow enough to allow the patient's lungs and the lung segments time to expand so that the alveoli can fill with air and medication. So this is what we attempt to do now. I think Ms. Bryce suggested that we show you how to set each piece of equipment. So the pulmonary ventilator actually is quite simple, and I think most of you probably, in using it all these years, have known how to set it. First of all, you have the knob here, which you use to set your pressure. Now I'm turning it off. To turn it on, you watch the gauge on the left. You can set your pressure anywhere from 5 to 25, depending on what the physician requires the patient to receive. course, the patient, as he breathes, this is what happens. This is the sound that you get. And what happens is that the medication that's in the nebulizer is nebulized as he inhales into his airways. Now again, with the pulmonary ventilator, the medication goes only into the patient's airways because he can't usually breathe deeply enough to get the medication any farther than about right here. It just can't go down that far. He's short of breath and he can't breathe. So, with the PV, you're nebulizing Isoprel, Turgimist, and Olivec into the airways. In short-term therapy, this is beneficial and it will give the patient temporary relief because it will relieve the edema and the spasm in his airways. Now, as far as long-term therapy, we prefer to use the positive pressure respirator, again, because of your controllable flow rate. You can set a flow rate slow enough that that patient can take a deep inspiration even though he's so short of breath that he can't breathe deeply. The respirator can breathe deeply for him and get the medication into the periphery of the lung. Now, as far as setting this particular respirator, and this is the one that I'm familiar with, I've been told that the Bennett also has a controllable flow rate. The Emerson also has a controllable flow rate. So those of you who use Bennett's or Emerson's or the other types of respirators in your hospitals, they probably are quite similar to the Bird. To set the Bird, do you use the Bird respirator? How many of you use the Bird respirator in your hospitals? Oh, good. It's wonderful. You have 3 dials that you're concerned with as far as the therapy is concerned. You have 5 dials on the machine and 3 that you're concerned with when you're using it for IPPB therapy. Now, on your left, you have the sensitivity. And this determines how much effort it takes that patient to start the machine. In other words, how hard does he have to suck in his breath to start the machine blowing. This should be set on 15. Now let me say here that the numbers on the machine, the sensitivity, the flow rate, and the pressure are relative. The numbers themselves have no bearing whatsoever. In other words, they don't mean 15 seconds. It's not a time element. They are relative to each other so that you can balance the machine. So the sensitivity can be checked first, and it should be set on 15 when you begin a patient on the treatment. Your pressure on the right-hand side of the machine is in centimeters of water pressure. This also should be set between 15 and 20. Now, the most important dial on the machine is your flow rate on the front. To begin a patient on therapy, this should be set on 15. Get where I can see it. Now what's going to happen, that patient is going to put it in his mouth and he's going to continue his normal breathing pattern, which is just about like that because he just can't breathe any more deeply. So one real important thing to remember is not to tell a patient when he's using this respirator to take a deep breath, because if you do, then you're going to have to break him of the habit of taking a deep breath. The respirator will give him that deep breath without his having to take it. All that he is required to do is to start the machine by pulling in on it with a slight effort. And once the machine starts blowing, the patient can relax and the machine will inflate his lungs. It'll automatically shut off when he has sufficient air in his lungs to fill them, and he can't get too much air. I know a lot of times the patients will tell you, well, I feel like I'm going to explode. but there's no way that they can get too much air because the machine will automatically cut off, and most of the time, when they feel like they're getting too much air, they're going to take it out of their mouths anyway. This, of course, is detrimental to what you want them to do. But, again, to start a patient on therapy, you have the 3 dials, your sensitivity, your pressure, and your flow rate set on 15. Now, you remember I said none of the numbers meant anything on the machine, that they were relative to each other so that you can balance the machine. There is a set of numbers on the machine that's important. Those are the numbers that are on the manometer on the front. And when you set your sensitivity, again, this determines how much effort that patient has to exert to start the machine. When it's on 15, and that patient pulls his breath in or inhales, the needle on the manometer will inflect very slightly 1 or 2 centimeters into the pink side. This is the negative side. Now, if the needle goes farther than 1 or 2 centimeters, the patient is working too hard. So to make it easier for him to start the machine, you move your sensitivity down to a lower number. The lower you have it set on the lowest number, the easier it is for the patient to start the machine. The higher it is, the harder it is. So you have to watch your needle, and it should go 1 or 2 into the negative side before it starts up into the positive side. Also, the numbers on your positive side, if they register 15, if this needle goes up to 15, then that patient is getting 15 centimeters of pressure regardless of where your pressure is set over here. It should coincide with the pressure that you have set on your pressure gauge. If you have it 15 here, it should register. Sometimes it won't, but this is what you go by. So we have the flow rate, the pressure, and the sensitivity on 15. We're going to watch the gauge and the patient to see whether or not the patient is using it correctly. Ms. Price, you want to be a guinea pig, huh? Before we show her at all how to do this correctly, we'll let her use it just to get the feel of it. And this is always a good idea because it frightens patients to death when they see it coming in the room for the first time. They can't imagine what it is. So it's a good idea to always let the patient breathe in and out with his normal breathing pattern to get the feel of the machine. And once he gets the feel of the machine and realizes that he has control of it, then you have his cooperation and you can show him how to use it correctly. Okay. Now don't breathe through your nose at all. Just get a good tight seal on the mouthpiece and breathe. Just breathe normal. Don't push. If you push, nothing will happen. You got to breathe. Be sure you don't breathe through your nose. You're breathing through your nose. Now, anytime this happens, this is continuing to blow, she's got a leak, either around her mouth or through her nose. Now, I think she's leaking through her nose and around her mouth. You want to hold your nose? Blow at it. Blow at it. Just breathe in and out a few times. Now, this is what you're normally going to see a patient do when they first start using the machine. They're going to leak. They're going to work like they're running up a hill to use it. She's going to be tired when she gets through. Okay? Come here, Bart.
I'm already
Tired already. Okay, now, to show you the difference, she was breathing her normal breathing pattern, in and out. Now, this time, and this is a little bit difficult for a patient or for anybody to learn to do. All that we want her to do is to suck, just like she's sucking on a straw, until the air starts blowing. The second that air starts blowing, she's to completely relax and not continue to pull the air in. In other words, she's going to suspend her breath, I hope, and let the machine inflate her lungs. You have to completely relax to do it. And be sure you don't have a leak. Just relax, start it, okay?
You said sucking.
Just suck in, and the second it starts blowing, relax and don't pull any more air in. Now it'll cut off. Try not to blow it off, but you're leaking through your nose again. Good. That time the machine cut off without her blowing back at it, and this is what you want to happen. See the difference in her chest expansion when she lets the respirator do it and when she does it herself. Even in a normal, healthy person, you can only breathe just so deeply, and when you let the respirator do it, you get such an inspiration that you can't get when you breathe in on your own. Another very important factor to remember with a patient is to be sure get your air out or you're going to get hyperventilated.
That's nice.
Makes you feel good. Okay. Another real good thing to remember is when they get a good deep inspiration, be sure you urge the patient to get all that air back out, because it's actually more important, or just as important anyway, to get that air back out as it is to get it in. Do you tell the difference when you breathe yourself and when you let the respirator feel it?
Oh, yes.
Makes a lot of difference.
You get the saturation, but it feels very jarring on the throat,
That's right.
And then it cuts off.
It'll cut off. It gets to the point where you think you can't stand it another second, and then it'll cut off. And this is exactly the point that you want to get to with a patient. Have you ever used a pulmonary ventilator?
Personally?
Mm-hmm.
No. I haven't.
I think we ought to get her on the pulmonary ventilator. Oh, if any of you have any questions, I'd like for you to ask them, because it would help me to know what you'd like to know about it. Yes, sister?
You just said to have to be sure that they get all the air out. That's the trouble with a patient with emphysema.
Right, they have too much air
Well, what do you
trapped.
do? I mean,
If they demonstrate, that's better word. If they, even patients with emphysema are going to get a tremendous inspiration when they're using the respirator. They don't have the power most of the time, particularly when they're breathing their normal breathing pattern, to get all that air out. They trap the air in their lungs. So what you have to do, it's actually an exercise, and when the patients begin to do it, it makes them sore until they get accustomed to it. But they squeeze the air out. This is what it would look like. I'm far from having emphysema, but we'll try to. Squeeze it out like that, rather than just breathing out. When you breathe, you still have quite a bit of reserve air that you can squeeze out, and this is one of the exercises that we try to teach the patients, is to get that air out as well as getting it in. Another thing you'll notice, when they get that air out, the more they get out, the more room they have to get it in, which makes sense.
thanks.
Well, does that stimulate the cough reflex?
Very
By squeezing the
definitely.
air out?
Very definitely. What happens, the air in the medication that use 20% alcohol or 4% saline with the bronchodilator, and it's delivered so far down that it loosens the secretions, and then by squeezing this air out, this helps to move the secretions up into the airways where they can be coughed out. It very definitely has a bearing on cough stimulation. Pressure gradient is tremendous. Somebody else had their hand up over here a while ago.
A
Well,
person with lung disease, if they had weak
Miss Solomon, could you, go in, Miss Solomon is the supervisor of the Steiner Pulmonary Clinic here, and I think she would be better able to answer that than I. She'd be more familiar with it.
I have heard Dr. Wumble comment on this, so I just have to quote him. He says that, the bird respirator is designed with a clutching effect so that, if the flow of gas in the lung encounters an obstruction, it doesn't just blast past it, as it would in the case of weakened tissue, but it clutches for a moment, eases up till the obstruction is passed. And I personally have never seen any occasion in which a bleb or anything of the sort was ruptured in the lung by the use of this machine, although many of our patients do have large blebs and so forth on their lungs, very definite areas of very poor tissue, but nobody up to date has had anything of this sort. And we've treated about 300 or 400.
300 or 400 patients a week, really. Another thing, yes, ma'am. Surely.
I heard the man once who had this blood respirator, you know, and had the tracheotomy, and he talked for 2 weeks about how painful that was. And I felt terribly bad about it, all of us did. And I should he have complained of being his own lung, both sides of his lung, he had cancer in his lung, but he had to use this because of the heavy sedation, you know, trying to commit suicide. And he kept telling about how terribly painful it was, and all of us felt so bad about it.
Well, one thing that it's real good to remember, several things really, to tell a patient before you put the respirator on him or as soon thereafter as possible the effects that he will have from using the respirator the first time. One of those is that he's going to have muscle soreness because he's going to be using muscles that he hadn't been using before. Those muscles are practically dead down here, and that's the reason. Another thing to remember that is a result. To these patients, coughing is bad, and of course, that's what the respirator is for, is to make the patients cough. So tell them beforehand that they're going to cough, and they're going to cough more than they've been coughing. When they cough up, the secretions that they're going to cough up, they'll range in color anywhere from light pink to deep rust. And this is from the medications that you'll be using in the respirator. And it's a good idea to tell these patients about this, because when they start coughing up this red mucus, they're going to get panicked and think they're coughing up blood. So these are 3 good things to remember. They're going to get sore, they're going to cough, and they're going to cough up red secretions. So I'd tell a patient before you put him on it that this is going to happen. I think we've covered, at least briefly, how this is used in therapy, and I would like to demonstrate to you, because I know on a tracheotomy and various other instances it's used automatically, and I think it's a good idea for the nurses to know how to set the respirator with the automatic control. Thank you very much for being a guinea pig.
This man said that was the worst experience he ever had in his life. The soreness from his blood respirator, that's all anybody ever heard. How hard was it?
No. This is. Was he sore in his lungs or up here?
Just everywhere. Horrible thing.
I hate to say it, but I think the patient might have been exaggerating a little bit too. More than a little bit. Okay. To use this on a patient who has no spontaneous respiration, you would again start your sensitivity, your flow rate, and your pressure on 15. Down on the bottom of the machine, the small black knob is your automatic control. It's your expiratory timer. Now, to use this on a tracheotomy, when you're using it automatically, when you're using it with a mask automatically, move your sensitivity handle down below 5 so that it'll start more easily. It'll start in just a second. You come over here to your automatic control and it's turned counterclockwise to turn it on. And there is no set way, there's no number, there's nothing that you can go by to set this except your patient's chest excursion and the respiratory pattern that you want to establish. And you have to stay there long enough to set it to establish the pattern that you want. And this is what's going to happen. You can set it fast, you can set it slow, but you can set an almost normal pattern on a patient who can't breathe with the respirator. This is an obstructed lung, by the way. You can see because of the flow rate, every bit of this test lung is being filled, even with the obstruction. It's taking the time to get down there and get back out, and all of the lung is being filled. Okay, any questions about the automatic control? One thing we didn't cover in using this in therapy, the flow rate does not normally stay on 15. And when the patient is using this in therapy, stay with him during that first treatment long enough to slow this flow rate down so that you get a good long inspiration, because normally when it's on 15 it's going to go in and cut off just like that, just real fast. So the lower you have your flow rate set, the better it'll be, because the lower the number, the longer it'll take that air to go in, the better it'll be. I think that just about covers it. One more thing before we finish. The medications that are used in this respirator, and as far as I know, in the other respirators that are used, the Bennett, I know, you use again the normal saline and the micronephrine or vaporephrine as a bronchodilator, and 20% alcohol as a wetting agent. Now the reason that you use this and you do not use Tergimes, Isoprel, or Alavir in the respirator for one particular reason. They're of a consistency that won't be broken up small enough to be delivered into the periphery of the lung. Your saline, your micronephrine, your alcohol are of a consistency that they can be broken up into particle size that can be delivered through the air to the periphery of the lungs, and your detergents cannot, and they fall out in the upper airways. So for this reason, when people question you about why you don't use your detergents, your Tergimist, and so forth in the respirator, this is the reason for it. It just can't go far enough to get the work done that you want done. Are there any more questions? Yes, ma'am.
Can you show us the nebulizer or the container for the medicine on that thing?
Yes, ma'am. That thing. This is the nebulizer. Looks like a space rocket. And it's filled always through the front. And you notice this has a cap. The reason for it is because this is an IV drip. You have a patient on a tracheotomy, you can attach an IV drip to it with a number 22 needle. But we have people who try to fill the nebulizers for therapy through here, and they puncture it, and then as it nebulizes during therapy, it sprays out. So always remember, when you're filling this, to detach it from the rest of the valve and fill it through the front so that you won't puncture this. Detach it. It's together into the right side of the exhalation valve, and it comes apart like so. Now to clean it, this is very important, because a lot of times your patient will complain to you that it's leaking. Always ask them where it's leaking, if it's leaking from here or if it's leaking from here. You're going to get a leak from here, and this is normal because you use an excess of medication in the nebulizer anyway, so you're going to have a fallout over here. But if it's leaking from here, the nebulizer isn't together well enough and it comes apart to be cleaned. thesis. When you put it back together, if you don't put it back together tightly enough, or if you should lose the rubber washer, and you're going to have a leak here. So always ask your patient if it's leaking, where it's leaking from. And you can tighten. Any other questions? If not, I think that should just about cover it. Thank you.
I'd like to thank Ms. Thomas for this informative and interesting demonstration. Certainly helpful to all of us, and to our program chairman for making this program available to us. Ms. Bryce reminded us at the board meeting that this was the finale for her series of programs that she has been giving to us the past 2 years. I doubt very seriously if we're going to let her coast very long on her laurels. We'll be drafting her if she thinks this is the finale. But thank you, Ms. Bryce, till you hear from her.
Do my pleasure, committees.
Oh, Ms. Atkins, you have a report on printing.
Of the 1,500 meters and 2,000 directories.
I believe, Ms. Mace, do you have a report on finance or anything else that you want to present?
I think she'd like to speak to the group.
Ms. Hudson, do you have a report on legislation? Ms. Davis, membership.
Ms. Atkins brought that out in her report. We have 1,066 members, and 3 new applicants to be approved, but their applications have not been completed yet.
Ms. Hicks here has something from the registry to report.
Madam Chairman, Mrs. Hicks is here. May I report for her? We had 1,691 calls, and we were able to fill 1,072. We had to cancel 191, and we've had so far 428 that we were not able to fill at all.
Thank you so much. Do you have anything in public relations?
Well, the one thing we did in public relations, since Ms. Mace didn't speak to you a minute ago, I think most of you know that she was chosen Nurse of the Year for 1963, and she is our official nominee to the Allstate Insurance Company for Nurse of the Year. As you know, they are seeking the outstanding nurse of the 14 districts, and you will be hearing more about that in August. We sent the features and the clippings with her credentials as our official member. And as you notice, the daily papers have had features on nurses. We did most of our publicity during Nurse Week.
Thank you, Ms. Atkins. Ms. Wells, do you have a report, American Journal of Nursing?
Well, they tell me 67 subscriptions have been cleared through the district, and I'd like to mention that according to the new policy of the A&A, now I believe your subscription goes directly to A&A for $3 per year, and the district, if you are a district member, gets reimbursed 50 cents for each subscription that goes in. Is that correct?
Yes, we got 50 cents worth of stamps for the first one that came in this last week. This is a new thing. We still will take your subscriptions and send them in once a month. But for the renewals or any new member who is a member, and they will check with us for your membership, you may go ahead directly to the American Journal of Nursing for the $3 if you're a member in good standing.
Do we have a report from Mrs. Jones on careers? Committee on Professional Practice, Ms. Wade. Ms. Wade has had a death in her family and has been out of town. Don't know if any member of her committee has a report for her or not. It's not. Mrs. Boggs, Committee on Insurance.
May I tell you that Mr. Henderson said that they did get 154 for major medical, and they were allowed to go ahead and not continue to start that. They told them originally they had to have 200 policies, but we were happy to hear that they were able to do it at any rate, 154.
The Committee on Functions of A&A, Ms. Graves. Now, do we have reports from the sections? Administrative, Ms. Pope? No report. EACT, Mrs. Robinson. General Duty, Ms. Davis.
There was a report in the district meeting, we did like, new officers at the meeting before the, T meeting. And, we will have a call meeting and then we'll announce when our regular meeting will be. It'll be printed in the meeting and we'll also notify the officers.
Thank you. Occupational Health, Mrs. Clark. Private Duty, Mrs. Hensley. Public Health, Ms. Armstrong. From the Alumni Associations, Crawford Long, Mrs. Hilton. Georgia Baptist, Ms. Fowler. Thank you, Ms. Fowler. Grady number 1, Mrs. Dixon. Grady number 2, Mrs. Stanley. Piedmont, Ms. Bond.
We had our last meeting in May, but, then Ms. Lucy Kimball then has been.
Mrs. Kimball.
We have not been notified, so if you don't mind, we'd like to have a report on that. We did not send a card to her for this past, and we needed a quorum Tuesday for the executive board meeting, so we appreciate it.
Did you have an announcement?
Only one on that psychiatric, you have a little card there that he announced in the meeting. You want me to read it?
You have an announcement.
They did not send us enough of the little brochures or pamphlets on this conference group on psychiatric nursing. So what I did, I sent them the ones that we had to all of the schools of nursing, and we will have one in the meter. But in the event you are interested, ANA will present an institute facing up to changing responsibilities in Kansas City, Missouri, on December the 2nd and 3rd, and the 1963 registration fee will be $10 for members, non-members $15, and if any of you are interested, we have this information on file.
Are there any other announcements anyone would like to make at this time? Do you have any new business you'd like to bring up? I believe then this completes our agenda for the evening. We have a motion to adjourn.
Madam President, before you adjourn, I don't like to turn my back. I don't believe I've done this right, but I would like to thank Madam President and each person who took part in the team, the program and the team, for the Florence Nightingale and for the award that was given, or the award, I should say, because it was three
we just hope our 5th District Nurse of the Year will be the State Nurse of the Year, Miss Knight, in the next, go around. Now, do we have a thing up? You want the card?
We would like those, we keep those and record them on the minutes, your roll call. Now, I say this is the first time we've ever had a meeting and finished it all up on one tape, to have had such a wonderful demonstration. I think that's quite a compliment.